Good afternoon. I'm Annie Williams, the Relationship and Partnership Lead for Hamilton Centre, and I'm here with Katrin Oliver, who's our Education Lead. And thanks very much for having us to talk today about tensions in the workforce, capacity building, and to enable integrated care. So thank you to Tom's earlier acknowledgement, and Hamilton Centre would just like to add that they acknowledge with deep respect all First Nations people and traditional owner groups within Victoria. And we also acknowledge the lived and living experience workforce and everyone accessing our services, because their expertise and experience helps us shape services that are safe, accessible and inclusive. Hamilton Centre, established in response to the Royal Commission, strengthens integrated care through statewide clinical, educational and research leadership. We have a central team responsible for referral management, workforce development and research, an advice line, and clinical partners from 5 hospitals delivering integrated care across the state. I'm sure you'll recognise the challenge. How do we build workforce capacity when we have limited resources, high caseloads, pressure to meet throughput targets, workforce shortages and workforce fatigue, and a little protected time for meaningful capacity building? We have the frameworks and guidelines that emerge from the Royal Commission, but how do we bring them into life in the real world?
Sani. So, our work from sector-wide consultation in 2022 and 2023, a forthcoming journal article and current co-designed demonstration projects show that effective workforce development requires attention to 3 interconnected conditions. The first is foundations, the prerequisites that must be in place before skill development. The second is relationality, how capacity develops through connection and practice. And context, the organisational that wasn't good. Let's go back. The organisational and system alignment that makes capacity building sustainable. So these work together. The foundations support relational learning, but they both need organisational alignment to be sustainable. And I feel we're the last speakers of this morning, and there's probably not much that we're going to actually say here that the others that have come before us haven't already said. So maybe we'll think about this as a nice rounding off of the talks today, with the focus on workforce development, but really a lot of what we're going to be saying you've already heard. But I will introduce a new concept. So this is the key insight that we bring, is around this idea of tinkering, and that you can work on all of these foundations through what Anne-Marie Moll calls tinkering, a strategic improvisation that finds practical ways forwards within constraints. So Moll describes tinkering as a continuous, flexible effort to improve care within particular contexts, adapting to changing resources, consumer needs, and institutional expectations. And I quote, "The task is that of attuning everything to everything else, one way or another. What to fiddle with and what to keep fixed is rarely obvious. What you try to do may not work out. Try something else. Keep on tinkering, caring. It would be great if the world fitted into little vignettes, but as it happens, there are always contingencies and surprises." So tinkering isn't ad hoc or chaotic, and it's not accepting inadequate resourcing as permanent. It's strategic improvisation that acknowledges constraints while maintaining our commitment to quality integrated care. And as we have already heard today, particularly from Nimai's wonderful work, you may already be tinkering. Informal mentoring between shifts, carving out time for reflection, adjusting role descriptions, inviting peers with lived experience to lead case consultations. These aren't comprehensive solutions, but they're practical improvisations that work within the constraints. So today we'll share what effective tinkering can look like for workforce capacity building, and crucially, how what you can tinker with depends on where you sit in the system. So condition 1, the foundations, which are the prerequisites. So before technical skill development, 3 foundations need to be in place. Like we have already heard today, role clarity is important. People need to know what integrated care means for their role. Without this, even great training can reinforce silos. Stigma reduction, especially towards people with AOD conditions. Confidence and stigma are linked. When workers feel uncertain about how to help, they avoid or deflect rather than engage. And system navigation. This is not just about referral pathways, but having skills in managing complexity, critical thinking, and advocacy. So these shape whether other capacity building initiatives succeed. For example, our demonstration projects that we're running with locals and an area service have identified that asking about AOD issues sensitively and managing intoxication are priority areas. But staff can't build these skills without first understanding their role, examining their own assumptions, and knowing how to navigate the system. So here's what happens when one foundation is missing. Staff go off and attend excellent AOD training. They learn about screening tools, how to do motivational interviewing, and all about evidence-based interventions. But they return to workplaces where their role in integrated care isn't clearly defined. So the training creates anxiety rather than confidence. Am I expected to do this now? Will I be supported if I try? So without role clarity, training can become a source of stress. So these prerequisites are interconnected. Role clarity supports relational learning. Stigma reduction affects organisational cultures. System navigation skills support confident practice within role boundaries. So some examples of tinkering to support foundational elements that we've encountered in our work include managers using existing meeting time to clarify how each role contributes to integrated care. Teams inviting AOD specialists to relaxed lunchtime learning sessions, and services adjusting intake workflows to embed system navigation conversations, modifying existing processes rather than adding new steps. Condition 2, relationality, about how we learn. Again, nothing new here today. This brings us to how the capacity develops. Our consultation work showed that while people acknowledge the convenience of online learning, they overwhelmingly prefer in-person opportunities. And regardless of the format, they want training to be cross-disciplinary and cross-sectorial, collaborative and experiential, co-led by peers with lived experience, built on shared reflection and practice, not just information delivery. So these aspects build trust, confidence, and partnerships. So our demonstration projects reinforce this. What makes a difference isn't completing courses or reading research, although these help, but relational approaches, peer-led support and modelling, reflective practice and debriefing, case-based dialogue, transdisciplinary case reviews, shadowing and mentoring, and collective problem solving during crises. Think of this as horizontal capability development. Solutions emerge from networked connections across disciplines and roles, not just through formal hierarchies or individual expertise. So we've designed our workshops this way. Our first workshops focused on those foundational elements, and more recently we've been teaching technical skills, currently the role of pharmacotherapy in integrated care. But we bring the foundational elements into this more clinical work. We bring together participants from different sectors and disciplines to explore the content and work through real integrated care case scenarios. This simultaneously addresses these foundations. Mixing groups helps people understand their roles in relation to each other. It builds confidence, creates shared language, and develops networks for navigation. So some examples of tinkering focused on relationality include a team building cross-disciplinary case consultations into their morning handover, a service pairing new AOD workers with mental health workers for their first few shifts, creating mentorship without formal programs. Staff are invited to engage with and learn from lived and living experience workers, or a manager allocating an hour a fortnight to group reflective practice carved from existing meeting time. But understanding your role and building relationships requires organisational support to sustain them. And this is where we know it can become difficult. Organisational and systemic changes must support capacity building efforts for them to become effective. From our consultation work, a dual diagnosis provider articulated, what knowledge and skills do the workers need? A much bigger question is what skills, knowledge and attitudes does their service need? We've done decades of training workers about integrated treatment. They go back to their host service and they find that the host services don't support integrated treatment. So without this alignment, workers who develop expertise may feel punished for it. Why professionals end up giving up is because the system doesn't change and the staff get punished for doing more. The more competent you are, the more you get overloaded with things. There's no return coming for that. So they become the go-to person, the AOD expert with larger, more complex caseloads. Without the organisational support and adequate resources, integrated care that relies on only a few people leads to burnout rather than improved outcomes. So tinkering at the organisational and systems level. Thanks, James. I'm almost done. So some examples of tinkering at this level include managers tinkering with how complexity is distributed across teams, adjusting allocation processes, or creating peer consultation structures. Service leaders might tinker with how integrated care shows up in position descriptions and team structures. Again, we're seeing good examples of that this morning.
Yep.
And those in government and policy might tinker with funding models that reward collaboration rather than just throughput, or they might develop accountability frameworks that measure relationship building alongside clinical outcomes. Over to you. Let Kat do all the heavy lifting.
So in closing, and this is critical, your leverage point depends on where you sit. We all operate within constraints, but we have different possibilities for action. The question isn't whether you can tinker, but what kind of tinkering your position enables. So beyond this, what we're describing is a shift from rational to relational models of workforce development. Integrated care is relational work. It needs to be taught relationally and supported organisationally. It isn't about more training, it's about strengthening the foundations, relationships and organisational cultures that make integrated care possible. And through whatever strategic improvisation your position allows. So rather than one-off training or quality improvement events or change, tinkering is an evolving and constant process of adapting and fine-tuning. It unfolds with different situations in practice and requires time to do, something which isn't easily accommodated in implementation plans involving discrete dates, actions and timelines. So our question, while keeping in mind the need for big picture advocacy and system change, what small practical improvisations could better align workforce development with the reality of your constraints? Not comprehensive solutions, but concrete, doable actions that acknowledge both the need for relational capacity building and resource realities. What forms of tinkering is possible for you? We'd like to thank the participants in our workshops and projects, our partners and our stakeholders who've contributed to this work, the Department of Health for funding our projects, James from NEMI for inviting us to talk, and also the contribution of Dr. Michael Savick. Thank you very much.
Thank you. Hello everyone. I am from the Collaborative Centre, Workforce Director. I just want to say thank you to all the presenters that have shared their work today, and to NEMI for taking the initiative and bringing us together for this event. It's great to see so much fantastic work, and I'm thinking about how we could share this more broadly with the sector. It's amazing to see so many people in the room, but we're thinking about how we can share things more broadly. I think I've had a question in my mind throughout all of the presentations about what organisations and the system needs to support integration and collaboration. And Annie and Katrin, I think you spoke to some of those conditions that could probably be applied beyond workforce development, thinking about the foundations and the relationality. And underpinning all of it, I think it's about relationships and the time and the space and the place to build those and to build a shared understanding across partners, whether that be system steward partners, service partners, or across disciplines. And I think, I think sometimes we fail to build in time for this. And I liked your call out for the government and policymakers to maybe build in measures around collaboration. I thought that was a great suggestion, because when we're faced with constraints, whether that's time or funding, sometimes the first thing to go is collaboration, and that does come at a cost. And I love the invitation to tinker. I think that creates something possible from sometimes a task that feels impossible. So thank you.
Thank you.